Amrit as co-host. Pawan, we can start the slides now.
Yes, sir. Just one minute.
So, very good evening to all of you. I welcome you to this 67th edition, post-Diwali edition of Thursday Musings. The housekeeping rules are very simple. The panelists will be able to unmute themselves. The audience will be in the mute mode. Any questions from audience, they'll be posted in the chat box, which the moderators will put at the end of the session to the speaker. So, and the meeting is being recorded on our Facebook page later on. Next slide, please. Let me hand over the session to Professor Dr. Tufan Pati sir. He's from Cuttack, very well known. And sir, I'm with apologies, I'm skipping your biodata as everyone knows you. Sir, over to you. Please skip mine and Amrit's too.
Sir, I've muted everybody. Only host and co-host will be unmute themselves.
Thank you, Alim. And I welcome everybody to this enlightening evening of Thursday Musing, where we have got a very good speaker, our person in UK, Dr. Pradhan, and our moderators, Dr. Amrit Patudasi and Dr. Alim Siddiqui, are vibrant members of IPS and expert adept moderators of Thursday Musing. I congratulate them. And Pawan, थोड़ा slide आगे करो. Dr. Krunal Patel, हाँ, और next slide भी आगे कर लो. Mr. Patel. Alim Siddiqui and Dr. Amit Patjoshi, there are moderators, their CV is presented. Next one, please. We are very much happy that we have got Dr. Rajesh Dhume of Panjim, Goa with us. He is a senior psychiatrist of the government of Goa. He is a nodal officer of the MHP drug treatment program, member of government of Goa Mental Health Task Force. He is co-chair of IPS Task Force of Physical Therapy 2018, co-chair of IPS Subcommittee on NGO and Carer 2019, and co-chair of IPS Subcommittee of NGO and Carers 2020. He is past president of IPS West General Branch 2018 to 19, and past secretary of IPS West General Branch 2012 to 14. National TOT, Suicide Prevention, Addiction Medicine, Government of India, and the JICA alumni of 2005. Welcome, Dr. Rajesh Dhume. We are pleased to have you. And I also welcome my dear friend, ever smiling, Dr. Pravir Pal from Kolkata. He is 42 years of experience in psychiatry. He is consultant president of Ishwar Sankalpa, an NGO working for the homeless mentally ill persons. He is life member of IMA, Indian Psychiatric Society, Indian Association of Social Psychiatry, Life Fellow of Indian Association of Private Psychiatry, ex-chairman of Election Commission of IPS, ex-direct council member of IPS, past president of Indian Psychiatric Society West Bengal State Branch and Eastern General Branch, is past president of Indian Association of Private Psychiatry, West Bengal Branch. With this, I shall hand over the proceedings, further proceedings to Dr. Paul and Dr. This will be introduced by the chairpersons, Dr. Paul and Dr. Rajesh Dhume, and I request all the participants after the webinar, please post your feedback in the Gmail ID of Thursday Musings, which is there in our announcement, and it will be displayed in the chat box also. Please respond, post your responses. Now the meeting is of the chairpersons, Dr. Paul and Dr. Dhume. Over to Dr. Paul and Dr. Dhume.
Dr. Paul, you have to unmute yourself. Yeah.
Thank you.
Yeah.
Good evening, everybody. And first of all, I must thank Dr. Tufan Pati and his and the trio, Dr. Tufan Pati himself, Dr. Amrit Patra Joshi, and Dr. Alim Siddiqui. So they have been instrumental in bringing these series of scientific programs, which is definitely very, very beneficial for all of us who are either in private practice or in other areas of psychiatry. So today we are going to have a very important session on transference and counter-transference, which is very, very important. Very, very important in the sense that if we undertake the process of psychotherapy, it is now a fact that the medication alone cannot give a full remission to the patient who are suffering from different psychiatric illness, mainly the anxiety neurosis, the phobias, the OCD, etc. So we have to go for psychotherapy and the sessions of counseling also. So this is an important area which we should be aware of, and we should be knowing the detail, the pathology, the genesis of transference and the counter-transference, so that we can carry on without any disturbances. Now, transference is a phenomenon in which the person is in treatment redirects the feelings for others to the therapist, as we know. And the counter-transference, which occurs when a therapist transfers his emotions to a person in therapy, and is often a reaction to the transference. Now, Sigmund Freud originally developed the concept of transference and counter-transference as a largely unconscious phenomenon. He described the counter-transference as a largely unconscious phenomenon in which the psychologist's emotions are influenced by a person in therapy and the psychologist's reaction with counter-transference. The classical psychoanalysts such as Carl Jung, who faced his own struggle with the counter-transference, characterized it as a potential problematic area that can inhibit the psychological treatment when left unchecked. And there is every possibility of either we should identify, sorry for my throat problem. It is necessary for therapists to master this tendency to participate in the unconscious counter-transference by developing a healthy boundaries and remaining mindful of the threat posed by the counter-transference, both to the therapeutic relationships and the therapist's work with people seeking the treatment. I think we should go to the main topic now. But before we start the topic, I would like to request Dr. Rajesh Dhum to introduce the speaker.
The pleasure is all mine. Thank you very much. It's always interesting to hear an Indian alumni speaking about something which intrigues our minds. Dr. Subhash Pradhan was born in Bhubaneswar. He finished his MBBS from MKCG Medical College in Behrampur. He did his MD and DPM from CIP Ranchi, and then went ahead to do his DNB in psychiatry. He migrated to Australia and worked there as a psychiatrist from 2000 to 2013. He had a stint in Dubai, UAE from 2013 to 2020. And since then, he's working in, as he says, a picturesque part of UK from October 2020. So, ladies and gentlemen, it's my proud privilege to present Dr. Subhash Pradhan on the topic of transference and counter-transference today. Over to you, sir.
Thank you. Let me just try to go back to my screen. Am I visible now? The slide is visible?
Yes, yes.
Yes,
quite
sir, you
visible.
are. It's
Good,
visible,
good.
sir. Go ahead,
Thanks.
sir.
That's the crucial point. So thanks, everybody. Thanks, Dr. Paul, Dr. Dhume, and all members of the organizing committee. I'm a big fan of Thursday musings since its beginning. I'm particularly in love with this word musing. that gives a feeling that, okay, it's like reflection. It's more than thinking. So that's it. That's what caught my attention. And more than academics, here we discuss day-to-day practice issues. Not necessarily we give references, but we discuss about the things that we usually don't discuss in other forum, mostly to deal with psychotherapy or psychotherapy-related issues. So today, I'll be talking about a topic which is, well, sort of core to psychotherapy, or in fact, all those elements of patient encounter that you have any clinical encounter. It's not limited to psychiatry. If you think that way, probably GPs and any branch of medicine where we come in touch with patients, this transference and counter-transference would be applicable. So, what you learn today? If we are mindful during this 35 to 45 minutes, we'll be getting an idea about what is therapeutic alliance and what are the terms called transference, counter-transference, and above all, what is not transference, as I mentioned here. Very often we sort of use it as an umbrella term, and the factors that increase transference, and obviously we'll be discussing a little bit about managing counter-transference and transference issues. And then we'll be discussing some pertinent issues about the tips, how you'll be identifying and how you'll be addressing those issues. Obviously, before concluding, I'll also be asking you some questions. I'm trying to make it as interactive as possible. So there will be opportunities in which I'll be asking you a question. You can answer through chat box, or if you're really interested to speak, also you can unmute and speak yourself. But that's something that I'll be trying to make it as interactive as possible. I'm sure the organizing committee, somebody will be helping us to navigate through the process. And at the end, as Dr. Pati also mentioned, please don't forget to leave your feedback. And if you want a copy of my presentation also, we'll be looking into that. Hence, in a typical academic style, I will give you a few minutes to browse through these 5 questions. So please go through it. You answer, you can put it in your chat box if you like, or keep it yourself, because the answers I'll be discussing at the end in the post-test questions, post-test answers. So please go through it. These 5 questions, I'll leave maybe another couple of minutes, 2-3 minutes, then we'll continue. Okay. So I hope you got enough time. It's just to be, you don't have to search the answer anywhere, just do it. I'll be answering the questions and much more during our discussion today. Well, let me start with this question then. What is the difference between God and a doctor? Think about it. The answer is in the next slide. Well, God doesn't think that he's a doctor. When I say doctor, I also mean therapist, I also mean psychologist and everybody. Sometimes we have or we suffer from the so-called God complex, that we know the answer for everything. So that is something was the point. And that is probably very central aspect of our discussion today. Sometimes we have to know our limitations. Therapeutic relationship is the basis of any clinical encounter. The client or the patient, the doctor, the therapist, the patient, they get together to have a dialogue, to have an interaction. And therapeutic relationship is based on these three major pillars. We'll be discussing all of them one by one at length. So the three pillars, as you know, one is therapeutic alliance, another is transference and counter-transference, which are the crux of our discussion today. So let me start with therapeutic alliance. Before I do that, your past task today. So mention in the chat box what you mean by therapeutic alliance. Then someone from the audience, one of our organizers probably would be summarizing and letting me know. We'll spend a minute or two on that. Then I'll be defining it myself. Please write down, feel free to write down in the chat box. I'm also keeping a tab on that.
So the audience is requested to write
write the responses in the chat box.
In the chat.
Even the door that I'll do it, but probably it's a good idea.
Yeah.
I'm also having a look on my second screen at the chat box.
Okay, sir.
Yeah, somebody said it's a harmonious relationship. Okay, to help establish trust and reach a diagnosis. I'm doing it myself. I'm doing, and to establish rapport with the patients. All right, let me just go to the next slide. It will be much more clearer. Thank you. And you can keep doing that, but I'll go to the next slide now. So this is what proposed by Bodwin in 1979. It has got three components. It's an agreement between the therapist and the client about the goals of the treatment. In the very beginning, there's an agreement. Second, the agreement is about the therapy tasks needed to accomplish those goals. So what you're going to do to achieve those tasks. Third, the emotional bond developed between the therapist and the client that allows the client to make therapeutic progress. So that is in short what is meant by therapeutic alliance. Thanks everyone for their for your own sort of explanations. In fact, that will be keeping you more engaged in our discussion today. So whenever a patient comes to a doctor or a therapist, counselor, apart from what is obvious, there are some covert agenda. That's important and that's crucial to our discussion today. Covert means something not overt, not obvious. So the covert agenda, sort of, I have summarized in the three sort of headings. One is relationships we seek is heavily influenced by our previous experiences, be it clinical, non-clinical. What we are going to seek is influenced by what we have already sought or what we have already found. Second, the most people can usually evaluate the expectations against the reality of the present and adjust accordingly. They know whatever we had in the past, probably the present will be something different, but not everybody. Some people cling defensively to their preconceptions or their previous experiences, and that colors the current experience. That's what I'm going to discuss today. All right, so that's about the covert agenda. Again, transference. So what comes to your mind when you hear this word transference? I know Dr. Paul defined transference, but I would like to hear from you. What do you mean by transference? So that I'll be discussing it at length. If you can write few lines in chat box, that will be good.
Few words and lines about transference in the chat box.
Transference, yeah.
In the chat box, please, audience.
I mean, even if they don't do that, that's fine. I'll be telling you. But if they do it, it will be more meaningful, more engaging. Yeah, clients feeling towards a therapist, feeling of the patient towards therapist. Someone someone all right mentioned. Anita Railas mentioned that what the patient projects on the therapist. All right, we're coming to that, the defense mechanism. Riti Kumari has written trust towards therapist. Pranay has written a patient is identifying with the therapist and develops feelings. Fantastic. I think we'll stop there. Thank you. So this part is made by transference here. Transference is a phenomenon whereby we unconsciously, remember the word unconscious is one of the questions we asked in the beginning, unconsciously transfer feelings and attitudes from a person or situation in the past onto a person or situation in the present. So there are a few components to it, isn't it? It has to be unconscious. The feelings and attitudes will be passed from one person or situation in the past to a person in the present. That's the essence of it. I will narrate a personal story just to exemplify that point. Well, it was, I was in Dubai at the time. I saw this lady in her 40s, I think. She was suffering from chronic paranoid schizophrenia. She had initially built a good relationship, just slightly stable on medications, although she still had psychotic symptoms. Behavior-wise was a bit more stable. She initially she sort of had a good relationship or a good rapport, but eventually I found that she kept on making frequent appointments. Probably it was a good thing for a private psychiatrist perspective, the way I was practicing in the private hospital then. But eventually, she became so obsessed that she kept on targeting me or sort of stalking me on social media and other places. And then at the end, I fully expected that the question came, "Doctor, I am in love with you." Well, I'm a considerate person, but on that occasion, I had to say no in no uncertain terms. I'll stop there, the story. My point was that when a patient makes an advance towards the therapist or the client or the counselor, there could be various reasons. One possibility could be this transference. Maybe I could have explored that more. I'm not going to diagnose that lady's condition, telling that it was clear transference. Maybe there's something else. It will be much clearer once we go ahead in our presentation. So transference is unconscious, as I told earlier. It's at least partly inappropriate to the present, as evidenced by in the example that I gave. Well, certainly that is not the forum in which somebody proposes to another person. Partly, I said, not wholly. Well, one can imagine that it could be, there could be partly it is appropriate as well. Third is that it is transferring of a relationship, not the entire person. Okay, that particular relationship, the transferring, that loving relationship, whatever. And only an aspect of the relationship, not the entire relationship, is transferred. So those are different components of transference. I'm just exemplifying that bit further. So somebody mentioned about projection in the transference. In fact, projection is one of those classical defense mechanisms, ego defense mechanisms that operates in transference reactions. So transference involves the projection of a mental representation of previous experiences onto the present. So other people are treated as though they are playing the complementary role needed for the projected relationship. They're part of that whole schema of things. They're subtle. There are subtle unconscious or the behavioral nudges to take on these feelings and behavior. So many a time, in fact, one can argue that the example I gave, not every relationship, every encounter like this is transference. We should not overdiagnose it. So not all feeling that a patient has towards his or a therapist should be called as transference feelings. There could be some appropriate feelings which do not constitute transference. A person can truly feel love, affection, hatred, anger towards the therapist. So that is not transference unless or until it fulfills all those three criteria I mentioned earlier. It has to be unconscious. It has to be based on some past experiences. It has to be partly inappropriate to situations. Real and appropriate affection, as I mentioned, with the idealization of the wish for an intimate relationship is not necessarily a transference. That has to be kept in mind. So factors that increase transference, what are the factors or who are the type of patients who are more likely to have transference reaction? The vulnerable personalities, especially people with borderline features, very often that happens. We'll be discussing an instance later on while discussing counter-transference. I'll be exemplifying it further. Who may rigidly project their expectations onto the present. People, they are more prone, mostly because of their weak ego strength, or various other psychodynamic explanations are there. Patient's anxiety about his or her physical or psychological safety when sick or afraid, sort of like, you are a last straw. So they're trying to catch hold of somebody. So they are more prone to have transference reaction. For somebody who's chronically bed housebound or always lying on the bed, they're more prone possibly. Frequent contact with the service or with the key workers. In this instance that I gave, frequent contact with the carer. Very often, real practice, case managers here in this part of the world, called case managers. In India, possibly we'll be calling them as social workers or psychologists who visit patients frequently, or patient very often meet them without meeting the psychiatrist. So those are the people who are more prone for transference. So quickly about how do you handle transference? Essential aspect of handling transference is to recognize it first. As I mentioned, all those aspects we discussed. Hopefully by this time we are slightly more aware or better placed to identify transference reactions. Recognizing the importance of the relationship with the patient, reliability, frequency of it occurring, and maintaining professional boundaries and clear limits in the treatment. It's very important to tell, like I did, yes, I'm a doctor, you are a patient here. And that's the only relationship we share in this platform, in this forum. So that has to be very well maintained. Sometimes that is not clear, but the so-called slippery slope you might have heard in psychiatric ethics, where that boundary is blurred. Okay, so that has to be there. You have to maintain that perfect boundary, because one of the quickest ways, I'm in India as well, in the Western world, to lose your license is to have an affair with your patient. So that's something you have to keep in mind. So be very careful about that. And a relationship based on transference or not with your patient, past or present patients, is unethical. And that is considered as a breach in medical, sort of in our therapeutic alliance. And that is considered as unethical by almost all medical boards. So interpretations, but only when the patient can understand and use it. For example, like a chronic psychotic patient, they may not be able to interpret it. The reason I mentioned interpretation, because transference is a core aspect of psychodynamic therapy. So the practical psychodynamics, if many of you have read Glenn Gabbard's book, talk about interpretation of transference. Sometimes transference is created to interpret so that you can analyze the psyche of the individual. We're not going to the depth of it, but partial interpretation is probably appropriate in many situations. There is a rather confusing term called transference in reverse. I thought of initially not discussing it, but we should know that there is a difference between transference and counter-transference, which we'll be discussing later on. But transference in reverse is often a feeling of a doctor towards the patient. It is not classically counter-transference. I will be discussing a little bit more while I discuss about counter-transference. So, coming to counter-transference. Now you got another 1 minute to write down in the chat box, what is counter-transference? I'll take a sip of water in the meantime. So, Group Siddhana, appropriate feelings can be understood in the light of counter-transference. What is counter-transference? Well, Subhangi Parker, counter-transference is an attribution of therapists' feelings towards patients, and therapists need to be aware of it and address it in therapeutic process. Maybe unresolved conflict and therapy is fantastic. We'll discuss that to an extent. Anita has mentioned the projection of therapist feelings from past towards the present to the present. Okay, therapist feelings for the limits, and someone else called Jum Jum Baba. All right, I didn't get a real name. I'm sorry. Unconscious feelings of the therapist towards the patients from past experiences. All right, so good. You got a good bit of feeling about that. So thank you for it. Probably most of the elements that we discussed is mentioned in counter-transference. This is just an illustration that I have put here in the screen. That it is when patient has feelings towards doctors based on past experiences, that is transference. The opposite traditionally is when the doctor has got feelings towards the patients based on the past experiences, that is called counter-transference. All right, that's the and the type of feeling would be like a patient would be feeling that towards God, Father, dependence. They could be angry, irritability, sexualized feelings, and from the doctor it could be like feeling sympathy, sadness, anger, frustrations. Probably all feelings both can feel. So that way there is some sort of commonality between transference and counter-transference. But I would like to draw your attention to these 4 points. This is probably crucial to our understanding of counter-transference. I have done a bit of background reading and have extensively presented this topic in many other conferences. Counter-transference include the feelings evoked in the doctor, when I tell doctor, also therapist, by the patient's transference projections. Remember, by necessity, a person should have some amount of transference for the doctor to develop counter-transference. If a doctor develops some sort of feelings towards the patient without patient's feelings, then that is not counter-transference. So it has to be primarily based on patient's expression of transference feelings. So that's the reason I was telling about maybe the feeling towards the patient from that angle could be reverse transference, as I was talking to you. So that is one component. The second component is this can be a useful guide to the patient's expectations and relationships. They are easier to identify if they are not congruent with doctors or the therapist's personality and expectations of his or her role. So somebody, you feel that someone who is not like that is spending more and more time with the patient and he behaving in a particular way. So that probably is a soft indicator that there may be a counter-transference operating. Awareness of the transference and counter-transference relationships allows reflections and thoughtful response rather than unthinking reaction on the part of the doctor. The meaning of this statement is that when it occurs, instead of getting panicked or instead of acting almost like a knee-jerk reaction, very often in a therapy setting, you need to discuss that with your counselors, with your supervisor, as we call that, or in psychiatrists, those who don't have supervisors all the times, we need to have some form of peer review, or your colleagues can tell, oh, that patient I had, and I have got this sort of feelings. What do I do? So it's important to diagnose, to elicit or rather to cast those counter-transference reactions at that level, at the beginning level. This is a story I promised that I'll be telling you. The photo is fictitious, by the way. One of my friends, it happened really. The name has been changed, and of course I won't be telling the name. I'm not naive enough. The time I probably was doing my undergraduation, post-graduation, he's the person who was doing his post-graduation from a very premier institute. He came across a lady who was probably suffering from borderline personality disorder or emotionally unstable personality disorder, who used to frequently present by self-cutting, self-harming behavior, and she had the precedence of other adverse childhood experiences like childhood abuse. So whatever the reason, after multiple times when this lady presented, doctor felt helpless. And he came to the solution that the best way to treat or cure the problem is to marry her. And he probably did without informing many people. But without any surprise, the head of the department and many other people in the department, they got together. They gave him an ultimatum. Either you have to leave this lady or leave your PG seat. And you know what happened? He did the latter. He left his seat and he went elsewhere. And of course, he's a psychiatrist now. So the point I mean to say is that Dr. Pavoli did what he thought was right at the moment, but then he lost all the chances of curing other patients in the future. Whenever I should have discussed about this, we have a sort of humor about it, we discuss about it, but at the same time, look at the dynamics that is operating. So that is one aspect about counter-transference. You can tell maybe there are other things mixed in it, but that's probably one example I thought of sharing with you. All right. So patients who do not get better. There are some patients, frankly, who want a simple contact or relationship with the doctor and have no interest in treatment or cure. They simply come, well, I just come there once every month just to say hi and hello to the doctors. And it happens so in countries where I am practicing now, or I have practiced before, that some people are so lonely. Doctors or therapists are the only people who can alleviate their loneliness. It may not be exactly replicable in India, or maybe so, I do not know. I've left India probably more than 10, 15 years ago. So I cannot really tell that, maybe 20 years ago. So a patient's loneliness could be an example why he or she presents to the doctors, remember that. And many doctors of the team, they resolve this problem with limited but reliable non-interventionist contact. Means you won't do many interventions, but you'll just have a quick chat, maybe 10, 15 minutes. And that saves money in the long run. Here's an example of a 50-year-old lady who had many depressive episodes and somatic complaints throughout her life. She was a frequent attender at her general practice. The GP found that a 50-minute monthly appointment kept her relatively well, and that her demands didn't escalate. If somebody will be telling that, okay, that is a wastage of person's time, patient's time and other people's time, they should keep in mind the fact that otherwise, if the patient didn't present here with the GP for 15 minutes, she will be presenting in the emergency or somewhere else, self-lacerating. So remember the importance of it. So as I mentioned earlier about reactions versus reflections. So a questioning attitude towards our own feelings and motives is what we call reflection. Reaction is more like a knee-jerk reaction, as you know it. Recognition that you all have blind spots. This is a very fundamental thing. I thought of devoting maybe a minute or two on this issue. I was working in Australia at the time, I think 2005-06. During that time, Catholic Church was riddled with criticism, sexual abuse, child sexual abuse, and so many other things happened. There was a royal commission which took place. And the verdict was really something to look at. They mentioned that everybody have their own blind spots. I got that word blind spot from that context. And everybody is vulnerable at certain points in their life when there is when there are opportunities. It's important for us, hence, to be mindful of those blind spots and take therapy, take counseling, take supervision. So that's the point I wanted to press, that we all should be mindful of our own blind spots. So understanding that a staff are affected by the patients as well, by these reactions that you have to know. And understanding that patients are affected by the staff's behavior, that is also important to keep in mind. A recognition that patients often have strong feelings towards the staff. As I mentioned earlier, it is not necessarily always that person is having a transference reaction. There could be a genuine reaction. A person may not certainly like a doctor or dislike or strongly like a doctor or a therapist for certain reasons. So one has to be aware of those features while you deal with transference counter-transference reactions. So reflection, as I mentioned, is the sine qua non, the primary thing in dealing with counter-transference as well as transference reactions. Here is important. Transference is initiated by the patient, but a doctor is responsible to resolving that. Counter-transference is, again, possibly initiated by the doctor in the situations which is evoked initially from the patient. But again, it's our responsibility to be doctors to address it. So using the term to clarify that a difficult patient projects into treatment relationships, often several members of the group can contribute to an understanding of the patient transference to the team or to the individual. Suppose we are not able to deal with that because we are in that framework. Maybe we have got a blind spot. So someone else, maybe more than one member, can approach that patient whenever there is an opportunity. In your real practice, clinical practice, maybe if you are finding some sort of counter-transference reactions or you're finding strong transference from the patient, maybe you can think about having another person present in the room. Using a specialist psychotherapist in some of the services that I've worked, they have got specialist psychotherapists for this type of issues. That also talks about how frequent this occurs, especially when you are talking about doctors or maladaptive doctors having issues with the medical board. So undergoing personal therapy to become more aware. Yeah, there are some psychologists only specialize in giving psychotherapy for this type of issues. So practical tips is that an understanding of transference and counter-transference is essential to good practice in general psychiatry and may be helpful, as I mentioned earlier, in general practice, especially for the GPs. And for any other practice, dermatology or anywhere, the patient interactions would be more frequent, more face-to-face interactions are there. So being aware of the hidden agenda is very important in a clinical relationship. So 5 questions I asked you earlier. The questions are here again. All right, we're coming towards the end of our presentation. These are the answers. Sort of I mentioned, for some reason, it is not highlighted. But I can tell you from my mind that, okay, as I remember, transference is an unconscious reaction. So number 2 is correct here. All right. So which defense mechanism is used in transference reaction? Many of you might have already put it there. This is projection is the one sort of, we're referring to here. So counter-transference is a feeling for the doctor. So what the response here, the answer would be yes, the third one. The doctor having strong feelings for the patients following their transference. Good. Somebody did, Anita. Thank you. What about the fourth question? The best way to manage transference by a patient is to, I'm just looking for any answer, anyone in the chat box, because here it's not highlighted. You want to explain to the patient, or it would be reflect the behavior? Yes, most persons would feel that it would be like reflecting on the behavior than transferring to another clinician. Yes, sometimes you do, but initial approach would be to reflect on the behavior, what's happening, or whether you can handle it yourself before transferring. And number 5. So some physicians are immune to counter-transference. What's the answer? It depends. Well, it fully depends. But most people, I mean, that's a wrong statement. Probably the answer is 2. Although I can see the reasoning behind why Anita said that it depends. but false is the answer, because most of us, as I mentioned, we all have our blind spots, and we all are prone for counter-transference. So that's the message I wanted to convey. So that brings us to an end to the formal presentation today. But I believe the informal presentation is, or the discussion part is most important, because you can get this presentation anywhere in Google. But discussion is where you can give comments, you can sort of ask questions, and you can give your own opinion. So it's all free now. So hopefully our moderators will be moderating it, or you can also use a question like the chat box. I'm reading someone's, Mohammed Hassan's, how many, so many thanks for this beautiful presentation, thank you. Would not facilitating patient encounters with the only lonely patient.
Sir, if you can stop the screen here, then we will have everyone on the screen.
Sure. Okay, so I'll be what do you call it?
Close your presentation.
Okay. So before I close, so please remember, there's a feedback button. You are all welcome to send your questions either in this email or the other email Dr. Tripathi mentioned, the generic email from your like the Gmail Thursday
Musings one.
Yeah, that one also. So only two lines you have to write what went well in my presentation or what could have been improved. I'm now sort of what do you call, leaving this stopping broadcasting. Okay.
Yes, sir. Thank you.
Am I there now? Okay, good. So yeah, we are now open for discussion. Thank you. It's good to see everybody now.
Let's wait for some
I was looking at the
questions.
blank screen.
Let's wait for some questions coming in.
Yeah, thank you, sir. Do we have any opening remarks from the chairpersons?
Not really. I think we should take questions unless if Paul sir has something to add.
Prabir, Paul sir has asked a question, sir.
Yeah.
How to deal with, sir has started with a very, very interesting question. Sir, you
Very
can ask the
interesting.
question, sir. Prabir, Paul sir.
Yeah.
Sure.
How to deal with the negative counter-transference?
Thank you, sir, for this question. I mean, it's a very common question, obviously. As you know, transference could be both positive as well as negative. I didn't discuss much about that. Sometimes positive is used to our advantage. For example, in classical psychoanalysis, sometimes transference is generated.
Yeah.
And they discuss about that. Negative transference, so remember, all mild negative counter-transference need not be what do you call, addressed. If it is mild, you can possibly discuss, you can reflect on your own. But when it becomes significant, means it interferes with your interaction with the patient, that's the time we think about interfering. And as I mentioned, the first port of call is always reflection. Think about it. And all of us, I mean, in NHS here, as well as I'm pretty sure in India also, there is a system in which we all discuss our feelings. We are all supervised to an extent. Those who practice solo, they have to be extra careful that once in a while they should have a group called peer group where they can discuss their difficult cases. There they can bring up this issue. See, I'm seeing this person, I'm having this feeling. I'm so angry with this person. For example, today I'm talking about, I saw a gentleman here in a red car. This guy who had got an extensive forensic history for armed robbery. He came here, the time he saw me last time, he was very sort of, he went ballistic for no reason. He was asking me to prescribe this medication only, he was talking about it from a racial perspective, all sort of stuff. So today when he came, I had this feeling, I'm going to see him again. So possibly I'll run away from the place. So I would tell that I had some sort of, I would tell counter-transference in the sense that he had that sort of reaction in the beginning. So what I did, I'm just giving an example here. What I did, I discussed it with my unit supervisor, the team manager, we call that here. See, I'm feeling these things and he's going to come again today. What do you do? I like to have somebody with me sitting. Otherwise it might again escalate further, especially he was a dangerous man. So these are a few things you can do. But to answer your question, yes, if it is serious negative counter-transference, yes, it must be discussed with your supervisor, if not supervisor, your trusted colleagues. We call it a peer group. If you don't have a peer group, please think of having one for good practice. Probably sooner or later it is going to come to India. It is practiced all over the world. It is important to have some sort of peer group.
Thank you. Thank you very much.
Thank you, Dr. Subhash. But one thing that I want to add here is that we will have to, Tofan sir will probably need to propose to the IPS, because it's a very interesting sort of thing that we should have some sort of a body, a peer body which we can relate to and discuss with. Like we have an ethical committee when we are presenting papers or writing a project, we should have something that supports us, wherein we say that, like Subhash said, that a peer review. We should have a standing committee that sits despite the change of presidency. I would personally like to propose that to the IPS, saying that we would like to have such a committee set in, so that if I have difficulties in identifying a transference, and I have identified a transference, what do I do about it? I would need some guidance, especially the youngsters who are coming in.
Absolutely. Absolutely. I think it's a fantastic.
That we have the standards. So, what do you think? Isn't it?
I think that's a fantastic statement. I mean, in fact, I was going to tell that there are to be two ways. One is that yes, IPS or the national bodies can look into that, but at the unit level, at your college level, or at the place they were practicing, there also you should have a committee which are easily accessible. The peer group committee that takes the edge out of it. If you do some mistakes, something happens, then the whole group is there to support you. So please think about that. If not there now, it's unsafe practice. So that is the danger.
It should be on a zonal level. I don't know. I mean, I'm just thinking aloud. I don't know. Maybe it's a zonal thing, because with this activism that is coming in time and again, and people targeting psychiatrists from time and again, Paul sir will also tell you, as a senior person, sometimes we have to deal with, as seniors, complaints coming out from our own colleagues. Sir.
Yeah.
Correct me if I'm wrong, but it's better before we commit something, we consult and say that, boss, this is my problem. This is where I am stuck. What do you feel?
Absolutely. Like, I believe that will also improve the quality of your care. Not only that, it will quality of the care, and that will be very ethical practice, if I can say that.
I agree with you.
Yeah. Thank you.
Thank you so much.
There is also always a possibility of boundary line violation. So that is the main issue. And if your friend is there involved in it, how can you get the clear view of the scenario? So that becomes a very difficult situation.
Yes. I'll probably tell a few lines about that, because that's a classic, there are other countries, particularly Australia, when they do the consultancy viva, it's a typical question there. What happens if you find one of your colleagues spending long hours with an attractive patient in a tea stall, right? That's what happens, in fact, many times. And the answer is not, you can't really tell yes or no, but the answer would be like that, yes, if you saw somebody like that, our job is probably, because everybody is supervised at a certain level, tell to the supervisors. If there's a peer group, tell to the peer group, see, I saw this person doing these things, I'm not sure what's happening. Could you please look into that? Those sort of stuff. In fact, it is mandatory. To some extent,
yes,
you have to report that colleagues of your, a colleague, for example, comes to your practice drunk.
You should be able to present a heads up for him.
Yeah.
So be able to present a heads up for him. Yes.
Our profession is at stake, not only an individual. Yes, the person is holding the whole branch in this respect. I mean, somebody is probably trying to malign the whole branch. So it's that important. So you have to keep that in mind. And a group, as Dr. Dhume was telling, is very important. Our ethics committee, IPS, if it has got one, they should look into that. That's my humble suggestion.
Thank you, sir. I think it is a wonderful suggestion by Dhume, sir. We as a Thursday Musing team could put it forward to the IPS.
We will. I will request Open Patti, sir. I would also give my remarks. I will write to Gautam Da and probably tell him about these things. That it's very important. It's ultimately about us having a camaraderie around and trying to help everybody. if one of us is just slipping around, we should be able to put him with no malice, but just to say that he keeps his dignity, his respect, and his ethics in place. That's the way we keep our profession in place, isn't it?
As Dr.
Otherwise,
Paul was
everybody requires somebody to be, cut to
Absolutely.
size, especially
So-
psychiatrists. We become sitting ducks for something. I
Absolutely.
agree
So-
entirely.
Unless
Yes,
we
Dr.
try it in the
Dhume,
beginning, unless we
it is
try
a
it in the
very good
beginning, it will
suggestion.
be escalating. Yes.
Yes, sir.
It's a,
Tupan,
yes,
sir,
it's
yeah.
a very good suggestion. We'll put it up to IPS for a consideration in the ethics committee. I think that committee can take care of it now.
Yes, sir. We should.
Simultaneously, please take note of Dr. Subhas Pradhan's comment. We can have some activity at our own place, because in case of crisis, that is a very quick to snap back with help to us. We can evolve. At least at some places, we can have a pilot mechanism that we have a peer group of ours, which can be of help. And let us see what happens. There's not local arrangements. It's not very difficult. It can be, and it can have also drawbacks, problems. We'll see it in due course of time. But we must attempt to have it, and at least and it comes. Transference or counter-transference comes. One does not intentionally develop this. So what will happen and how you'll manage it really in your setup is more important, because
Yes.
cultural background of Bhubaneswar, where we are practicing and where Dr. Pradhan has been brought up, that is totally different from other cities even in India. Forget about abroad. So that context has to be taken into consideration. And I
Absolutely.
think, yeah.
Sure, sir. Sure. Subhas, sir, taking this negative counter-transference further, when is it a right time to not see a patient then? Transfer to a colleague or transfer to a department?
Yes, I mean that is entirely depends upon. I can't be more prescriptive there, but that depends entirely on your call. For example, this lady I was talking to, I gave an example. All right, she was the transference was getting so much. My personal life was involved, so I was thinking that this is time I should transfer. All right, and counter-transference is the other way around, because you remain blind to that. You think probably you're doing the right thing. The group, the peer group discussion Dr. Pati was talking about, that probably can give you some advice about that, or somebody who observes it. So that will be the right time to think about changing it altogether, like transferring to someone else. Maybe the person can, and it might happen, like some patients, they are constantly angry with you. They don't want to see you. And that's the reason some doctors change the hospitals. Instead of changing the hospitals, we can change the patients.
Yep.
So that's one of the things. I think there are many questions. I can see the
Yes,
chat
yes,
box. If you could.
Yes, sir. I think.
As the case are discussed, no, about a lonely patient. So
Yes.
as a corollary to that case scenario, wouldn't facilitating frequent encounters with the only lonely patient so to absorb their loneliness and distress be a reinforcer for iatrogenic dependency and making them more distant from being self-sufficient? You talked about a patient who is lonely, who comes to
Yeah.
they come to meet you. Now once you start giving them time, giving them all the attention they want, it's type of a dependency
You're
on,
right.
and they can't go back to society again. So that's
Yeah.
the
Let me sort of answer that question. I think it's very close to my heart. And that's a burning topic in so-called developed world. Okay? People have got their basic necessities met in Maslow's hierarchy. All right. So the upper necessities are still unfulfilled. There's an existential vacuum. We had existential therapy last time, isn't it? People have left. They're all there. They've got food and shelter, but they don't have anyone to talk to. That's what constitute majority of plus 50 plus, or semi-retired people. Nothing else is there. And that is the biggest epidemic, they call that. Loneliness, if you don't know, that predisposes people to heart attack, depression, various psychosomatic illnesses. So government is facing a big challenge how to address loneliness. Talking about doctors, yes, I do agree that is a band, say patchwork therapy. It's not that I'm going to help it, but that is at least something. Then waiting for the patient to present in the emergency, cutting himself or herself. All right. That is one way. Obviously, there are agencies. First, you see that we do not do only after seeing their particular patient, what you do usually in these situations, there is something known as medical prescribe, what you call non-medical prescribing. You'll be surprised to know that non-medical prescribers are there. They prescribe exercise, they prescribe, somebody caring, somebody will be coming and doing the assessment. Does the person need a carer? Okay, those sort of stuff we do. And then the person would be requiring specific type of maybe some sort of rehabilitation. There's some rehabilitation college, we call that, is there. So that depends upon the services, the social input which is available. So yes, loneliness cannot be tackled just by seeing them once, but that's a good beginning. We can begin a person before, say, trying to commit suicide. The person comes to the doctor, 80% of the time they talk about it. So maybe we can find some cues out. We can do a suitable referral, or here we call it as a safeguarding. Safeguarding is a part of our treatment. Yeah. I hope
Yes,
that,
there is an interesting question. Suppose by Dr. Uday Kumar, that is the counter transference high in juniors who are wishing to have huge practice and money early and not able to have quality of time with the patient. Few of them are prone to develop counter transference early. What would be the specific temperaments? Any ideas on that, sir?
yeah, I think that's really a good question. I thought initially I'll ask Alim and my friend Amrit about that. I mean, of course, I'll not tell that you are very, very young, but you certainly have practiced. But yes, young people by nature, they are naive, and that's what the medical ethics comes into play. And the PG students particularly, who think of curing everybody. I gave the example of the God complex. We try to fix everything. We are able to, we are the, that sort of feeling we have got immortality or invincibility. That's not the case. We know that as you grow older, isn't it? Hence, in that context, when people are younger, naive or junior, yes, they are more prone for counter-transference type of reactions. To mitigate that, what you do, we have the systematic things, local as well as systemic. Local is college, everybody's juniors are supervised by the senior registrars or senior resident, as you call that in India, or the assistant professor. They have to report the cases. Some of the supervisions, some of the psychotherapy sessions must be seen through a one-way mirror or whatever is possible. Those are the minimum things that we should do. And if a person is constantly doing the same thing, counter-transference, irrespective of our instructions to the contrary, then they might have to think about some sort of more punitive, more sort of aggressive steps, like that was done for the gentleman I told. He was asked on certain topics whether he should be living with his love or he has to leave psychiatry. Okay, so those are the things, and yes, it should be started from early, and younger people are more prone.
I understand that two things are very important, and one has to be very, very mindful while taking these sessions, and the other one is one has to be mindful about his own limitations, that how to go about that. If he finds himself in a relationship or a developing of the positive relationship towards a patient, towards a client, I think it should be stopped rightfully and then referred to another colleague. Or else, now how can it be an unconscious process if the therapist becomes aware of his feelings towards a client? So it can't be an unconscious process like that. So one has to be very, very mindful about the total procedure. Otherwise,
Yes.
Very difficult to complete that.
Absolutely. Thank you.
And so just to add to that,
I would
Priyanka
like to add something.
posted.
Allow me. What happens to a patient who is constantly not being taken up by doctors because of transference issues? Who takes up this patient?
Interesting question.
Very, very tricky questions.
I mean, so, okay, probably I'll just try to, other people can answer, but my view is that, I mean, probably it is a bit too much stress upon imagination. There are many doctors and many services. And there are people who are constantly in trouble with one service to another. They have a track record. Some people assault doctors. Okay, those are the persons we must tell that there's a background noise. They are the persons we must be careful and we must report to the police. It's not the doctors can create doctors can sort of, treat these patients. Maybe magistrate, Lord, or they have to look into that. Okay, so we have to know our limitations. As Dr. Paul was saying, we have to know our limitations, because some patients do not come for treatment. They just come to visit you. They have to come to create nuisance. Okay, that you have to know, keep in mind. But if that is a problem occurring again and again, yes, we have to, as you're telling, initially probably starting by giving some interpretations. If the person accepts or not, then you change the doctor, someone else comes. But if everything fails, well.
Sir, we have a patient of, emotionally unstable personality, sir. Now,
Yeah.
a lot of transference issues with, suppose, one doctor. The doctor does not, that is one of the core criteria of the patient. The patient is coming to treatment because he or she is getting attached too fast, too soon. And then the expectations are too high. And even from the doctor, I think the personality will be across all situations. So he comes to, suppose the patient comes to Aleem, he has problems. Now Aleem does not want to look at the patient because he has a roaring practice. He can live without seeing another patient, which is a little problematic. So now he comes to X again does it, and then but the patient needs treatment. Now we cannot just drop. I have seen a lot of patients talking, labeling patients, stigmatizing patients. Borderline, nothing can happen. We can do nothing with this. But that is why they are coming to us. We cannot drop them just because they are, that is their criteria. That is why they are coming for treatment. So
yeah, absolutely. I mean, I agree with you. We must not drop anybody.
Can
we
we
were not talking about dropping
to improve our patients?
Dr. Amit, sorry to interrupt, but what I'm telling,
Absolutely
we're not dropping
right.
anybody here. We're talking about taking a practical stance. I mean, we are doing our best, whatever is possible. We're changing therapist, we're changing the persons. But suppose some people, I mean, we have limitations. We cannot treat everybody. And these are exceptions and the rule that the person will have trouble with everybody. They sometimes strike. There is something else probably they're trying to say. It's not maybe we need to understand them more sometimes. Okay. But there are situations in which we cannot help, and we must tell the person that, see, I cannot help you. It's up to you where you go.
Let me give an example. Dr. Tufan sir is the head of department in my medical college. I have a problem, and the patient goes to Tufan sir, and Tufan sir says, I cannot look. Then who will look after the patient? Tell me, sir. Where are our ethics now?
It's Dr. Tufan sir's responsibility to delegate somebody. He has to, because
he's the last resort. He's the last resort. Now, where will the patient go? That's my only question.
So he'll come to Goa to me.
Sir, welcome, Dr. Nirmala sir, also from all the way to.
Nirmala, welcome.
I have
Hello.
another aspect which I have encountered. I don't know how to present it, but young doctors who start practice encourage transference is what I feel, because they would probably get repeat clientele and build, and they would themselves say that, oh, I've got such a fantastic rapport with this person that मेरे को छोड़ती भी नहीं है, आती रहती है, मेरे को क्या, मैं उससे कमा रहा हूँ.
There is every plausible explanations are there, huh?
Isn't it, sir?
In psychiatry.
Absolutely.
So where do we sort of see? This is now I'm talking about somebody in private practice. Now, in an institutional setup, we can handle this.
Yes.
But in a private practice setup, when the individual is an island of excellence, somewhere in the remote part of India, where this is occurring,
Yes.
जितना बार वो मेरे पास आएगा, उतने उससे कमाई होगी. Then what do we do? Maybe a very lopsided question, very disturbing question, may not be pertinent, but this is how.
Yeah, that's all right.
Isn't it, sir? Subhash, so this is what
some questions would not have answered probably. I must say that. But my first thought is that, in the situations, sometimes positive transference is not a bad thing if we can improve patient compliance. But to the extent that it is to the detriment of the patient, then you are somehow violating this basic Hippocratic oath.
Exactly.
That is true, but who is going to monitor that?
Ethics committee.
I'm worried.
But again, you can't really do anything about that immediately, for everything. That depends upon case-to-case basis. But as long as we remain true, we think that, see, one way of understanding is that, if I think the patient who is coming to see me is my best friend's relative All right. So from
Hmm.
that point of view, that's the framework. If I go, then whatever I do should be in his or her favor. So please keep that in the mind. Anything more than that is something which is not right, which is unethical. But how to address that, I do not know. It's all depends upon our individual parameters, ethical standards. Anyway, it's open for everybody.
Sorry, this just came to my mind, so I presented, but
No, thank you.
it's an aspect that we need to think about.
Sure.
I think Neil Madhav sir is here if he wants to make a comment.
Yeah,
Sir.
Dr. Kaur, yes. Thank you. Welcome, first of all. And yeah.
Oh,
So there is some sound.
A bit of background noise.
Coming.
किसका माइक से निकल रहा है?
अलीम का
अलीम का। अलीम क्या हाल है?
Let's put everybody's mic mute.
mute all, please.
I think this is the mic dysfunction of Neil Madhav sir. Neil Madhav sir, your voice was breaking. Yes sir, please try again.
Yes.
Sir, please reconnect.
sir reconnect sir
Yeah, there's some problem in his mic.
Neil Madhav sir, please log out and reconnect.
By the time Neil Madhav reconnects, I am quite fascinated by the question put
Yes,
up
please,
by
carry on.
Amrit. I would like to humbly have my submission. There are certain sharp aspects. First thing, the patient comes to us in good faith. We cannot deal a patient with suspicion that what he would be doing to us. Number one. Number two, transference occurs. There are very few cases where transference does not occur. It is a manipulation by the patient. The doctor has to know that. When transference occurs, then one has to be a little soft and must practice how to deal with transference. The catch is that where we deal with patients and we practice psychotherapies, there the chances, but when this just supportive psychotherapy while prescribing, which most of us research in a country like India, where there is a high treatment gap. So there is very little scope for transference to create a problem. And just dumping the patient around is not possible. Think of a small place, 3 or 4 psychiatrists. Every psychiatrist has a bias for any person who comes because all of us know each other. Even in city of Bhubaneswar, maybe all the patients who come to us, their somehow or other become introduced through some channel. And third thing is counter-transference can also be used therapeutically. But at times counter-transference takes the shape of body-centered counter-transference when it becomes problematic for the therapist himself. One must learn how to judge it and at times what Dr. Paul told, that young psychiatrists want that transference to develop. So that is the point where it becomes malpractice, not a practice.
Exactly.
Yeah.
Correct.
We are
That is
defending
what-
practice. We are defending good practice.
No, I agree with you, sir. But how do we sort of, because it disturbs the flow of psychiatry, no? It doesn't.
But I think
ethical
that
part
is
of
the
it.
responsibility of the person only.
Yeah, it is a
Someone
responsibility
is
of the
doing
person, but-
malpractice, then he is doing malpractice, he or she.
No, the malpractice can be done by the patient. Malpractice can be done by the therapist also.
Yes, sir, exactly.
Oh,
Sir, there's a question in the chat box. I think 2-3 times
Yes,
it has come. This how to differentiate between negative countertransference and disliking a patient due to their personality traits or sticky behavior, such as in obsessives and borderline persons.
Very good.
okay. I'm just I'm trying to understand the question a little bit more. So you're saying that negative counter-transference and negative transference, you said. Negative transference and disliking somebody.
Is there a difference between this?
See,
Liking a
the
person?
basis
and
we are talking
liking a
about
negative
in this,
countertransference?
disliking is a conscious process. Let us go back to the when a dilemma, go to the definition, basics, right? transference, counter-transference are unconscious phenomena, unconscious. We do not know it operates. Disliking, we dislike somebody knowingly. All right. So if by sometimes, you feel that there is a person has got a consciously, he's disliking, he's angry, he's upset, he has got some other covert agenda, for example, as you're discussing. All right. So we have to be mindful of that. There is no sort of litmus test for that you'll be able to do it. As long as you know that, see, the basis of counter-transference is what I'm telling about. When the patient had some transference reactions, and then we, based on the transference reaction, we react in a way. All right. That becomes counter-transference. So as long as you are satisfied with that, that is something that requires psychological treatment. If anything else other than that, well, probably we have to think that it is a bit of manipulation, as you're telling about, or a personal liking, disliking. That has to be dealt. That is not necessarily mental health. That is something else. I know that it's not the foolproof answer, but that's the best I could possibly give in this situation.
Yes, sir. So there's a comment in the chat box that if in the beginning of the therapeutic alliance, we discuss the do's and don'ts and discuss certain boundaries. So will it help to avoid these issues later on?
I think it's a fantastic question, I must say that. And I should have told, maybe you didn't get the time to tell that all therapeutic encounters should begin with this disclaimer that, okay, what you are doing, this is the trust between the therapeutic 3 lines, as I mentioned about, okay? One is that you have some responsibilities, I have some responsibilities. You have to do these things, I have to do these things. If you don't do either of us, the therapy is broken. The alliance is no longer there. All right. It has to be by default in all therapies. For example, in the interview, what you do in our CIP or anywhere else, for example, when you do the interview, we tell people that, okay, most things are confidential, okay? Nothing is going elsewhere other than, suppose you do tell something which is of so much importance or life and death situation to someone else, I might have to break the confidentiality. So those things should be paid. In other places, like Dr. Kaur might have been able to tell, in the countries that I've worked, there is a standard policy. When they come to a clinic, they get this charter. They have to sign it, patients. Then doctor signs it. So yes, that is very essential. If it has not been done, this is again a part of our ethics committee to look into that, whether we could implement it in one way or other. In our, hopefully this seminar, this discussion is going to give some sort of suggestions to our committee, to our IPS committee, to implement some of those very important aspects of good clinical practice.
Well taken, sir. Thank you.
Sir has been speaking non-stop for now 80 minutes.
Well, I have okay.
Madhav sir is online. Let sir speak. Sir.
Yes.
So, Madhav, sir.
Am I audible now clearly?
Yes, sir, clear now.
Oh, thank you. And thanks very much for organizing this pretty nicely, pretty well. And thanks, Dr. Pradap, for your excellent talk about that. I wanted to challenge a different thing. When we have academics institutions, we have a lot of time with the patients, we have sessions, these things definitely and meaningful, useful to know and all that. But most of my colleagues in India, what is happening is that we are busy practitioners. I salute them with so many patients they see with such a short time and pretty effectively though. So hardly they have time for any meaningful beyond the medication conversations, and because they're extremely busy and they are giving great service, helping patients who can be managed medicinally. Where is the scope for this? And is there any, my suggestion is there any new things coming up? Whether we are doing any studies on this, like how it is affecting our clinical practice, whether we are utilizing this to improve our clinical effectiveness. Okay, has there been any studies now? I think it is high time. While psychotherapies are being modified to shorter versions, now CBT is available in 15-minute sessions, while we can do it in our clinics. Similarly, a lot of changes are happening. So is there any change that has happened for this part, like counter-transference, transference, and whether we can do anything about to improve our clinical practice?
May I take it, just for one sort of, before I sort of, other people can tell. My point is that, here, when, 1,000 good landings in an airport doesn't make news. A single bad landing does. All right, let's remember that principle. So far the air safety is concerned, isn't it? So thousands of people, when a BG practitioner sits, doesn't make any news, except sometimes one patient comes, with nowadays the social media, they do certain things. The doctor is behaving me way, doctor is treating me, holding me, and solacing me. So those things can make bad news, and that is equally wrong for the whole profession. So what I'm telling you that BG practitioner, yes, I do understand, but here also there are chances that something will be missed. And our job here, what we are creating, Dr. Kaur, you must be knowing that we are trying to create an awareness that these things occur. We are all having blind spots. We should be aware of that. Education, the primary prevention, that's what we are doing right now. So once you know that, okay, we will be able to devise some sort of ways. I don't know how we'll be doing it, micro techniques or something like that. And we are all talking about this psychodynamics, of course, that is getting a bit obliterated, as you know, classical psychoanalysis. But psychodynamic informed therapy that we are talking about, that we should be able to do that. We should know some basics about this transference, counter-transference reaction. The medical students should know about it. And they should be able to address when something like that happens. Somebody they know is doing something wrong with their patients. They must be able to tell it. They must be empowered. Our system should be empowered that they should be reported. Because those, the so-called, what do you call, one bad apple that spoils the whole reputation of the branch, isn't it? That's what should be our approach. And it's a good beginning. Good to think that way. When there is a BG practice, it is all the more needed, rather more needed than a practice where people are everybody's objective. It is difficult, but there has to be some sort of ways, some sort of means, but I don't know what exactly. Only one thing that we are doing here, bit of awareness. I mean, this is my 2 cents.
Thank you, sir. Amrit, have you covered all the questions?
Yeah.
I think there are 1 or 2 case descriptions.
Sure.
But I think queries we have covered. Any other queries that are there?
I think we can call him. We can have another session. Continue on and all. It's 9:30, I think.
Sure. I mean, this is a very important area. Well, you can discuss at length.
People can, email to sir. Has already shared his mail ID.
Yeah, for the feedback.
Feedback as well as if they have any queries, and sir can directly answer. I think sir has spoken enough. He needs a rest.
No, that's okay. I'm okay. I'm used to a lot of long sessions, but today, in fact, I came a bit early. That's fine. But as long as you guys are okay, I have no problems.
Alim is always okay. He can stretch it to 12 o'clock in the night.
I know it is light now. Here it is, I think, only.
But he wants to have the email shared again. RJ.
I think Dr. Suhas.
Yes, please.
Sir, if you can type the email in the chat box.
My email.
Yeah, someone has asked, this session has been recorded. It will be posted on our Facebook page, Thursday Musings at 8. So if you miss
last
anything,
name, gmail.com. That's fine, but I'll do that here. Right now I'm doing it. Okay. And in fact, they can send it to you as well. Your Thursday gmail.com. I think that's much
our
better.
email is on the brochure and all the links that we are posting.
Yeah. So that will be much better actually.
Yeah. So you can post your feedback, what went well and what could have been better.
Yeah.
So I think it is now over to the chairpersons for their remarks. Chairperson, sir.
It's been a very interesting sort of debate and amazing presentations. A lot of our issues that were there in our minds have been cleared. A lot of debatable questions have been raised and answers to which have been aptly given. So I think it's been an amazing time spent together trying to enrich ourselves as compared to transference and counter-transference, which we face day in and day out. We also have been warned about certain things that we should be doing, certain things that we should not be doing, when we should be trying to contact our senior persons to try and get the best out of our practice. So I feel I am very thankful to Topan Pati sir and Aleem and Amrit for trying to get me on board as a chairperson, and to my senior Dr. Paul. I think we should hear Dr. Paul to conclude this session, because it's very interesting and it's been very enlightening for us to listen to Dr. Subhash, who has given us a perspective which is very complete and apt for this situation. Thank you very much.
Thank you, sir.
Dr. Paul, you're...
Yeah.
Aleem, Dr. Paul is there? Yes, sir. Please go ahead, sir.
We had a very good session on the subject. It was sort of a recapitulation for me to go through this topic and listening to the speaker, and the inputs which we received from the audience and from the viewers, they also were equally important, because though I have been practicing for last 42 years, but the things became faded. So I have left the psychotherapy part because it's because of the time schedule and the pressure, and for my benefit too. I have not, I've given up psychotherapy. I do a bit of supportive psychotherapy in addition to my pharmacotherapy. But that was an excellent subject, and reliving the, going to the memories of therapeutic alliance, the process of transference and the counter-transference. It was very, very beneficial for me also. So thank you, Dr. Subhan and Dr. Tufan Pati, Dr. Aleem Siddiqui, Dr. Amrit Patrajashi, and to chair the session with a great Dr. Dhume. So thank you all. We can conclude here if the organizers feel. Over to the organizers. Thank you.
Sir,
Over to you, Aleem.
1 minute more. Tufan sir.
Okay,
Tufan, sir.
I should not come in the way of conclusion of the program, but it is nice. Dr. Subhash Pradhan and we have a very intimate common friend who was with him in Australia. So I talked to him beforehand before inviting to this meet. And what I shall speak is in a lighter note. I shall tell a story. Someone asked, what is the commonest profession? And someone answered, it is doctor. How? You go anywhere, tell I have a problem, they will give you some suggestion. And when people keep on giving suggestions, people keep on accepting suggestions, because in our place they rarely visit the therapists or doctors. And in that way, there is also a state of transparency and counter-transference that develops. But we are not concerned about that, because we are concerned about only this condition where we pay for that process and where we are paid for that process. That makes the difference. But the mechanism is universal. Developing dependence, developing weakness unknowingly. We don't know. And developing the reverse has also takes place. As it was told in this beginning by Dr. Pradhan, that it is not only with respect to our profession, it can be with respect to other vocations also, other doctors also. One has to be conscious of that, and it is our duty to make others conscious of that. And thank you, Dr. Pradhan. We'll meet again.
Thank you very much.
Thank you, sir.
Amrit.
Sir, बोल दिए thank you everybody बोल दूंगा.
Okay.
Thank you. Bye-bye.
Am I permitted to leave? I think-
Yeah, yeah.
Thank you, sir. Thanks a lot.
Thank you very much,
Really
Subhash.
nice.
Nice
discussion.
having you.
Much, sir.
Very, very good discussion. I really enjoyed it. Yep.
Thank you. Amazing.
And I hope
meeting.
something comes out of it, IPS thing you're talking about. That really be a
Yeah,
very
yeah.
good step.
Suggestions
should-
that were generated.
We should
Very
have
good.
something to,
Yeah. We should. I should.
safeguard our own people.
Absolutely. And this
Important.
is a bit of
Yes.
our service to the minimum thing that we can do to our society.
I will email Tufan Pandit.
Thank you.
Yes.
Thank you so much. Bye-bye.
God bless. Take care.
Thank you so much.
Pavanji?
We can close the meeting now.